At my practice, we are passionate about breast cancer care. The best time to meet a person for breast reconstruction is at the time of diagnosis, because that's when we have the ability to make a plan together for the entire course of treatment so that we can get a great reconstructive result. A plan of care that involves both the medical and surgical oncologic aspects of care, as well as the long-term plan to get a natural reconstruction result. It's important that patients who have a diagnosis of breast cancer, who know that they're having a radiation treatment, understand that implants will not be a durable, symmetrical, long-lasting reconstructive option. When a patient has radiation of the skin and chest wall of the breast, it can cause long-term changes to the physiology of that tissue, reducing the blood flow to the skin, causing fibrosis, stunting the ability of the skin and subcutaneous tissue of the chest wall and breasts, ability to fight any infection. So when a patient has had radiation, they have a higher chance of developing infections of the skin, of the breast, or the chest wall. They also will have a higher chance of developing scarring or fibrosis of that tissue, which can negatively impact the cosmetic result over time if an implant is placed. When there is a breast implant under the chest wall, the body will build a scar pocket around that implant, and that's called the capsule. And that's present anytime there's a foreign body in the breast, or anywhere in the body that there's a foreign body, such as a knee replacement or a pacemaker. Any place that something foreign is in your body, the person's body will create a scar pocket around that device. Anytime there's a device inside the body, whether it's a knee replacement or a pacemaker, the body creates a scar pocket around that device, and we call that the capsule. It's a sterile pocket that the body creates. The pocket is created out of a layer of scar. But if that scar has been irradiated, the scar will tighten over time. Over months and years, the body will create a firm, tight pocket, causing a breast implant under a thin layer of skin to become hard or firm and to raise up on the chest wall. And these asymmetries can become visible even in clothes. It also creates a 5 to 10 time increase in the rate of infection around that implant, which can result in loss of the implant, removal of the implant, and ultimately in reconstructive failure. So when a patient knows they're going to have radiation because of their breast cancer diagnosis and they have not had their mastectomy yet, I like to plan a 2-step reconstruction. My preference is to do the mastectomy, remove the gland from the breast, and if we can, we'll place a babysitter implant inside the pocket, whether that's a silicone implant or a tissue expander, holding the skin shape, holding the shape of a breast. Then we radiate that breast skin. Later, we remove that implant or remove that tissue expander. 4 to 6 months after radiation is complete, we can take out that temporary breast-shaped device and place living tissue in the pocket. That living tissue will be typically a DIEP flap, although we can also use a PAP flap for someone who does not have a lot of tummy tissue. We can use the posterior thigh. We place living tissue in the pocket, and that brings its own healthy blood supply, which nourishes the skin, and it prevents the formation of that tight scar pocket over time. So the patient gets a soft, living breast made of their own tissue that lasts a lifetime.